Now session number 12. So please, I need from the chairpersons to come on the stage. Professor Atif Basyuni, Professor Fahmi Aimara, Professor Hamdoun El-Hassani, Professor Hazem Ashmawi, Professor Muhammad Naguib,
Bismillahirrahmanirrahim. I'd like to welcome my colleague, Chairperson. This session will include two important subjects. The first one is NAFLD association with our common type 2 diabetes, a further comorbidity, by Professor Abdel Khalik Hamed, Military Medical Academy. Please start.
Bismillahirrahmanirrahim. Good morning, everyone. We all know that hypertension and dyslipidemia are comorbidities for diabetes. Today, the question is NAFLD association with our common type 2 diabetes a further comorbidity? The story of NAFLD started here. NAFLD was documented as the hepatic component of the metabolic syndrome more than 25 years before. 10 years before or more, the consequences of NAFLD was shown to be not confined to the liver. Few years before, it was shown that there is a bidirectional relation between NAFLD and all the components of the metabolic syndrome. Most important is the relation with type 2 diabetes. There is a vicious circle between NAFLD and type 2 diabetes. Presence of NAFLD increase the occurrence of our common type 2 diabetes. We should know that the prevalence of NAFLD globally in the general population is 20 to 30%, and it is 30% in Egypt. The presence with type 2 diabetes is about 70 to 80%, and in morbid obese, it's about 100%. So a very dangerous relation. The presence of NAFLD, as we will see, is independently a risk factor and increase the prevalence of cardiovascular disease and increase cancer, especially the story of HCC, the hepatocellular cancer. The natural history of our disease, NAFLD, fortunately, is simple steatosis, which is 90 to 95%. In this condition, it's not associated with impaired survival. Most of the cases will go as a stable disease. Very, very rare non-cirrhotic HCC can occur. However, on the other side, 5 to 10% will go to non-alcoholic steatohepatitis, NASH. 40% of those NASH will be fibrotic. Third of them will be cirrhotic. 10% of these cirrhotic will be decompensated, and the HCC will be 1 to 2%. Unfortunately, we have pediatric NAFLD NASH like in adult, so the obesity in our children is now documented to be very dangerous situation. So we have a clinical impact, as we mentioned, for this NAFLD, the relation to metabolic syndrome, diabetes, and now we will see how it increases the angiogenesis, the cancer, sarcopenia, and the very recent issue, or the re-highlighted issue, the thyroid function. So in year 2007 and 2008, Tergier showed significantly higher prevalence of cardiovascular, cerebrovascular, and the peripheral vascular disease, also retinopathy, chronic kidney disease in diabetics with NAFLD than in those without NAFLD. And after that, the Framingham Heart Study confirmed a meta-analysis evaluating 27 cross-sectional studies showed NAFLD is independently associated with subclinical cardiovascular changes, the increased carotid artery intima media thickness, the arterial stiffness, and the coronary artery calcification. These are now studies or tests to check for the occurrence of cardiovascular disorder. After that, there is growing evidence to show the independent role of the presence of NAFLD independent of other known risk factor or racial background in causing cardiac complication, most important in the coronary artery, the cardiac hypertrophy, dysfunction and the failure, the aortic valve disorder, and the mitral annulus calcification. Also atrial fibrillation and prolongation of the corrected QT interval. What about the putative mechanisms linking NAFLD with cardiovascular and the cardiac complication? As we know, the expanded and the inflamed adipose tissue with the altered microbiota are the causing factors, the most important causing factors in the pathogenesis of NAFLD NASH. Now, recently also, this gut microbiota affect negatively, direct effect on this adipose tissue. Now, this will lead to the cardiovascular disorders we discussed, and the NAFLD presence is an independent factor. Again, it will lead to the insulin resistance and the dysglycemia, the most atherogenic dyslipidemia, and the inflammation. Also, the thrombophilia, this is very important, most importantly due to factors produced by the liver itself, most important the plasminogen activator inhibitors. These will lead to the cardiovascular disorders we mentioned. The same occur with the kidney in the form of fatty kidney, which will lead to increased chronic kidney disease in diabetics with NAFLD. Interestingly and recently, in this study, the correlation between fatty liver disease and chronic kidney disease, it is shown in this big study with about 30,000 subjects enrolled, that NAFLD per se was not a risk factor for chronic kidney disease. But NAFLD patients with advanced fibrosis faced a higher possibility of chronic kidney disease. Also, another interesting recent longitudinal observational studies have emphasized the importance of advanced fibrosis as a determinant of NAFLD outcome. So, we should have fibrosis, advanced fibrosis, to present this effects of NAFLD regarding the cardiovascular and the kidney. A more recent presentation discussed the mechanisms played by causal role in atherosclerotic cardiovascular disease, the same as I mentioned before, but with increase in the hepatic specific proteins produced by the liver to cause this increased risk of atherosclerotic cardiovascular disease. What's interesting is the cases of gene polymorphism, which are very common, causing NAFLD NASH. In this condition, there will be fibrosis, cirrhosis, hepatocellular carcinoma, but the occurrence of cardiovascular disorders is questionable. However, in obese children, adolescents with a definitive NAFLD had a more severe cardiovascular risk, and similar findings for this were reported in Egyptian obese children. Our next issue is the hepatocellular cancer. In this multivariate analysis of variables associated with hepatocellular cancer, we see that the presence of diabetes just increase the risk ratio for cancer, hepatocellular cancer, just more than 2 folds. However, the HCV increased by more than 100-fold, and hepatitis B increased by more than 250 folds. However, although the risk ratio of diabetes, obesity, metabolic syndrome do not approach those of HCV or HBV, they are far more prevalent condition than HCV, HBV. So, the HCC related to obesity, diabetes, metabolic syndrome will likely increase in the future. So our dream regarding decreasing HCC after eradication of HCV in Egypt will be failed. We will have a more occurrence of HCC. In addition to this NAFLD and extrahepatic cancer, cardiovascular is first cause of this in NAFLD. The second cause are malignancies at both gastrointestinal, liver, colon, esophagus, stomach, pancreas, and the extraintestinal sites, kidney in men and the breasts in women. Regarding the colorectal cancer, unfortunately, the adenomatous polyp with high-grade dysplasia occur in the right colon with difficult and late diagnosis. So NAFLD patient should undergo closer surveillance for colorectal cancer. Our last issue, أنا مش شايف الوقت بتاعي الحقيقة، ربنا يستر. فاضل 5 دقايق، ده حلوين قوي. So my last issue is very interesting. The story of thyroid dysfunction as another clinical situation with NAFLD. It was shown, this is a rehydrated issue, it was present. It was shown that the plasma thyroid hormone concentrations is associated with hepatic triglyceride contents in patients with type 2 diabetes. Also, in pediatric age, TSH significantly increased in accordance with the extent of steatosis, ALT, and BMI. Now we have an interesting study published 2016 about the thyroid function and the risk of NAFLD, the Rotterdam study. This was the first prospective population-based study classifying the patient according to the overt hypothyroidism, the subclinical hypothyroidism, the euthyroidism according to the hormones of the thyroid, the subclinical hyper, and the clinical hyperthyroidism. The study in about 10,000 patients followed for about 10 years. the story showed lower thyroid function is associated with increased NAFLD risk. This finding may lead to new evidence regarding NAFLD prevention and treatment. How? Another study regarding the prevalence of non-alcoholic fatty liver disease according to TSH quartiles, showing again increase with the increase of TSH. The study suggests that thyroid function, even within the normal range, is associated with metabolic syndrome through which it may play a role in NAFLD. At univariate analysis, higher TSH level were associated with the diagnosis of NAFLD. This again opens a discussion if a lower TSH level could prevent the metabolic syndrome risk factors and thus the emergence of this dangerous NAFLD. A meta-analysis, 13 studies found a high correlation between hypothyroid and NAFLD. TSH elevation, even within the euthyroid range, is an independent risk factor of NAFLD and more may influence the progression of liver fibrosis, a very important issue. So, we have now a study demonstrated the efficacy and the safety of low-dose thyroid hormone therapy for NAFLD. In men, thyroid hormone or thyroid hormone analogs may be beneficial for this condition. Also, there is a growing complexity of thyroid hormone-regulated hepatic autophagy as a mechanism with advantages associated with the thyroid hormone autophagy axis-based therapeutic strategy, including, again, thyroid hormone analog for improving the therapeutic outcome of NAFLD and HCC. Very interesting issue. In this year, April 2019, in the EASL randomized phase 2 trial of
حضرتك حلوة بتجري بسرعة.
دقيقة واحدة.
هو عذر حضرتك ان التايمر ما كانش محطوط قدامك، فانا عذر حضرتك. التايمر ما كانش محطوط قدام حضرتك على السكرين، فانا عذر حضرتك.
So, randomized phase 2 trial of VA2809, an investigational thyroid hormone receptor agonist versus placebo in NAFLD with hyperlipidemia. This is an investigational oral small molecule prodrug of thyroid hormone receptor beta agonists. It's a novel liver-directed thyroid receptor beta agonist, significantly reduces liver fat in patients with NAFLD. Here is the design of the study showing the different dose of the drug in comparison to placebo. 12-week follow-up showed significant reduction in LDL cholesterol, liver fat content more than 30% versus the placebo at week 12. Significant reduction in lipoprotein and apolipoprotein be the drug was safe. So, ladies and gentlemen, to conclude, the patient with type 2 diabetes should be screened for NAFLD and vice versa, as it is accompanied by a higher insulin resistance and worse metabolic profile. However, these conclusions are our consensus-based guidelines in managing diabetes and liver published by our Egyptian group. Also, NAFLD patients are at increased risk of cardiovascular disease and should undergo periodic cardiovascular risk assessment. Aggressive treatment of classical cardiovascular risk factor is advisable in type 2 diabetes patients with NAFLD. HCC related to obesity, diabetes, metabolic syndrome will likely increase in the future. NAFLD patients should undergo closer surveillance for colorectal cancer. Finally, the thyroid hormone for preventing emergence of NAFLD, improving its therapeutic outcome, and HCC is very challenging. Thank you very much.
Okay. Thank you, Professor Abdel Khalik, for this updated talk. And of course, this is, I think, the upcoming epidemic, the NAFLD and the NAFLD-related complications. Now you raise the new issue also, or the old new issue of thyroid dysfunction. Of course, we need to emphasize that even the relationship of NAFLD to hepatocellular carcinoma does not need from the patient to go through the whole spectrum of the disease, and we see so many cases not going through steatohepatitis and steatocirrhosis, and the only first presentation is the hepatocellular carcinoma, especially among diabetics like you elaborated in your very elegant talk. Now we can open the floor for a 5-minute discussion before our next and eminent speaker. So if any questions from the floor to Professor Abdel Khalik Hamed, please proceed.
اتفضل استاذ علي.
اتفضل دكتور علي بيه. مايك يا جماعه في القاعه بعد اذنكم. مين يا جماعه كان معاه البورتابل مايك فين؟ دكتور علي بيه هنا.
أولاً بشكرك أستاذ الدكتور عبد الخالق حامد for this updated presentation, but I would like to ask you, can I use thyroid or thyroxine in the treatment of NAFLD?
This issue is the challenge now, and the first clinical study was this one presented in EASL, using a special simulating drug for thyroxine directed to receptor in the liver present in the thyroid. This drug will decrease the dyslipidemia, the most atherogenic dyslipidemia, and the fat in the liver, that's NAFLD, and very interesting, a little small